While we wait for other colleagues to join in, you can just join in and wait a little as other colleagues join the webinar. And I would like to welcome everybody who is joined, and please feel free to participate fully in this very important global webinar organized by the Global Nutrition Cluster with support from colleagues in Myanmar. Thank you. As part of introductions, I think you can also include dropping your names and the organization you represent, where you're based currently, in the chat box. That could also help us to understand each other as we start this webinar today. Thank you. And again, as we join, I could just read through the agenda items that we're going to be focusing on after the welcome and introductions. We're going to get into hearing a presentation on the introduction of CVA for nutrition outcomes, definition and basic concepts, the status of the evidence, main approaches and challenges and opportunities. And then after that, we'll have a Q&A question and another segment that is going to be hosted or managed by Mr. Sunini. After that, we also have a presentation on cash voucher assistance in Myanmar overview. And this is going to be from John Nelson on cash voucher assistance in Myanmar. And after that, we get to understand a case study from Save the Children that's going to be presented on this. And then another question and answer segment will follow after that. And finally, a conclusion and recommendations will be entered into as part of the schedule for this webinar. So as part of introduction, I hope all have joined now. We face quite a lot of challenges in Myanmar as a cluster in terms of responding to the increasing needs for humanitarian response following the conflict and everything else that is happening in the country, which has resulted in more than 17 million people needing humanitarian assistance. And among these, we know that the nutrition cluster has a people in need, which is a PIN of just over 2 million. And the targeted beneficiaries for this is just about 500,000. And the budget in terms of financial requirements for the HRP, for the nutrition cluster, is just around 48 million. We do face quite a number of challenges in terms of funding, and hence the need to expand the options that we could use to reach out to the needy, which is going to also include cash voucher assistance. It is also one of the thrusts that OCHA does promote or support partners or clusters to concentrate on, and hence we've had internal discussions within Myanmar to see how CVA can be expanded to reach out to the needy. And it is not something new though, because cash voucher assistance has been operational, but more focusing on other areas and also development nutrition as opposed to nutrition in emergencies. And hence the webinar with support from the GNC is to start off with this introductory webinar. And then after that, some activities will be entered into vis-a-vis maybe getting an advisor to be able to support a drafting of guidelines that will be tailor-made for the Myanmar situation. So it is on the basis of this background that we gather here for this webinar. And I think as a way of introduction, this is all that I've had to let us know, and over to the next part of this webinar. Thank you.
Maybe I can go next. Hello, everyone. My name is Marina Tripaldi. I am a senior cash and voucher advisor and co-chair of the cash working group under the nutrition cluster. I'm really delighted to be part of this panel today. We will have a few other presenters. We have the cash working group, one of the cash working group co-chair, John Nelson, who really kindly accepted to give us an overview of the use of cash and voucher assistance in Myanmar. And we also have Mirza Dermo, that is the Child Poverty Technical Lead from Save the Children Myanmar, who will guide us through a case study from the country office. So we can start with some introductory concepts on the use of CVA for nutrition outcomes. And I will really kick off, next slide, please. I will really kick off with what the evidence and guidance note is proposing as like some of the key information that we need to have when we want to start to use CVA for nutrition. We will look at the main approaches. The evidence and guidance note identify 5 main approaches. We will look at the evidence available and what is telling us in terms of effectiveness. And we're going to talk about some of the common challenges and some case studies, some promising practices in this area. Next slide, please. So the evidence and guidance note, it's a publication that was launched in 2020 by the Global Nutrition Cluster as an initiative of many organizations that have invested on the use of CVA for nutrition. And next slide, please. We have as I said before, thanks to the evidence and guidance note, we have identified 5 main approaches where we can use the CVA as a combination with other complementary activities to prevent or treat malnutrition. The first main topology is really the most used when we use a cash or voucher to support household assistance, mainly household food assistance. And they can be also combined with cash or voucher that are delivered to support individual feeding assistance for these individuals that are considered at risk, pregnant and breastfeeding women, children under 2 or children under 5. The second typology is also one of the most used, and is really when we combine cash or voucher assistance with context-specific SBCC. And we have seen that there is a growing use of this typology. Cash and SBCC, cash and voucher and SBCC, they are really complementary to each other. If we do not give resources, it can be limited, not to talk about behavior change, to try to influence some behavior for families that are really suffering poverty or are really suffering economic deprivation. And similarly, we have seen that when we accompany the cash or voucher assistance with some key messages that can really influence decision-making on expenditure, or can really influence positive nutritious behavior, there is a better outcome. The third typology really promote the use of cash, mainly cash as a modality, as an incentive to attend free priority preventive health services, typically to attend antenatal care, postnatal care, or all the child and maternal health services that are required, no? For the children under 2. And very often the transfer value for this modality is calculated to cover the cost, cost associated to transportation, or sometimes is also designed to cover basic needs or any priority needs that these poor families have and that are considered as economic barriers. But cash and voucher assistance can also be used to support children that, caregivers of children that are enrolled in nutrition treatment services. And this can be for some children or mom children, or also pregnant and breastfeeding women. And normally, in this typology of approach, we try to cover costs that are associated to access to treatment. So all these, again, all these costs that represent an economic barriers for accessing and utilizing nutrition services. And the typology number 5 include all the situation in which cash and voucher assistance are provided to the caregiver of some children with the purpose of improving their treatment outcomes, or with the purpose of preventing relapse. So typically in this case, the transfer value look at covering all the needs of these families. So basic needs or access to a nutritious diet. They can be delivered during the treatment service, or they can be delivered after when these children or these pregnant women are discharged from OTP center to sustain their recovery. So for the typology number 4 and number 5, as I said, there is limited evidence. So those are growing typology of approaches that are more and more used, but where we still need to build more evidence to really understand how this can impact positively nutrition outcomes. And next slide, please. In 2022, the Global Nutrition Cluster has done a study on challenges and promising practices on this area, and we also mapped the major initiative that we are using CVA for nutrition outcomes in the last 4 to 5 years across the different regions, really. And we have identified that, as you can see in this graph, CVA is still largely used to improve access to fresh food and to diversify the diet. However, you can see that there is a growing use of CVA to improve access to mom and son treatment, but also of CVA to improve, to prevent relapse. But I would say also the use of CVA to access to health services. Next slide, please. I would like to highlight that we might have a different perspective as well when we use CVA according to the typology of problem that we are trying to solve. Typically, in emergency context, in a humanitarian response that is looking at funding of short term, and we typically look at prevention of wasting as main objective, prevention of acute malnutrition, or try to reduce acute malnutrition rate. So in this case, and obviously protecting against an increase of stunting in countries that are suffering both stunting and wasting. So in this case, we might have projects that have 6 months, 9 months, 12 months of funding. So how do we cover the so-called opportunity window, the 1,000 day that covers really this critical period for the child from the moment of conception until the 2 years of birth. Is not always easy. So we really consider the 1,000 day the timeline for the best timeline for providing a CVA support. But if sometimes funding are not available, what we really propose is really try to build on consequent cycle of funding to try to go as long as possible. But sometimes with humanitarian funding, we might have to implement for 6 months, 9 months, or 12 months. In this context, we have seen that both modalities, cash and voucher, can be used and are often used. Sometimes in isolation, so sometimes unconditional and unrestricted cash as in the form of multi-purpose cash assistance is the most typically used in emergency context. But in other cases, we have also seen a combination of cash for houses, food assistance, and vouchers for individual feeding assistance. So really to keep in mind that that's the type of setting that we have in this type of setting. Next slide, please. When we look at more long-term programming, when we look at, solving a more chronic type of malnutrition, and also try to build solutions that want to solve like structural problems, we really propose to work as much as possible with government and try to build as much as possible the social protection system. Again, we are trying to prevent malnutrition, so the problem in this kind of long-term programming would probably be stunting, but with, of course, linkages and referrals in the instance of wasting. However, when we have this type of long-term program, the modality that is most used is really unconditional cash. And yeah, it has been proven. We have different example where unconditional cash for covering the 1,000 day has been proven to be effective for the reduction of wasting. Next slide, please. Still on the design of the CVA assistance, I'm just focusing a moment here on the design of the transfer value. There are different methodologies that can be used to design the transfer value of cash or voucher, and it really depends on the objective of our program. If the objective is to provide access to a nutritious diet, because we have seen that in our situation analysis, this come out as the main problem, and there are other actors that are covering other type of needs, then the transfer value will be designed to cover the minimum food basket that is meeting the nutritional requirement of gaps of the houses or individual. And in this case, we really propose to design a transfer value that is taking in consideration the needs of the houses and also the need of the individuals. we're going to see in a minute about the evidence, but there have been limited impact when CVA was designed only to cover the needs of the individuals. And the tools available to design access to a nutritious diet are typically the NUT-VAL and the cost of the diet. However, when we operate in contexts where houses have been exposed to different shocks and for life-saving purpose, we realize that they have multiple needs, and our priority from our situation analysis is really to give them access to a multiple series of basic needs and services, including a nutritious diet. The most appropriate methodology to design the transfer value is really the multi-purpose cash assistance. So we're going to look at the minimum food basket that is also meeting the nutritional requirement, but that is also taking in consideration non-food expenditure, including housing, health, water, whatever expenditure is relevant to nutrition and is considered as a priority need by our households. And the methodologies are the minimum expenditure basket that is calculated using a CALP or WFP interim guidance. Next slide, please. So let's have a look at the evidence. Next slide, please. What is the evidence telling us in regards to the use of CVA? As I said before, there was a growing use of cash and voucher assistance in the last 10 years. And we have seen really a big push from the Grand Bargain and from different NGOs, because cash in particular, but cash and voucher, they really allow our beneficiary to be empowered and choose what they need in terms of quality and quantity. And as such, different NGOs have really invested to try to see what's the impact of the use of cash and voucher for nutrition outcomes. And with the purpose of harmonizing these different approaches and try to learn from each other, in the 2020, the nutrition cluster published the evidence and guidance note, which is really trying to propose some standard operational guidance, some standard approaches that can be utilized by the practitioners. And it's really as a follow-up action that this working group, this global working group that I co-chair, has been created, really to facilitate learning and also promote some investment on evidence generation. Next slide, please. So the evidence and guidance note really highlight how CVA is linked to the UNICEF, our reference, the UNICEF Child and Maternal framework for malnutrition. And it really shows us how, to what level of determinants CVA can be impactful. CVA has mostly been impactful in the underlying determinants, so less impactful on the immediate outcomes, like the nutritional status, but consistently increasing individuals' purchasing power and households' purchasing power to access services for adequate food, adequate feeding, and adequate health care. Consistently effective when it is associated to SBCC or health services in increasing attendance of this attendance to this typology of services. But also it has been really interesting how by giving more cash or by giving more vouchers to women and to houses, it immediately has a sort of like a secondary effect in decreasing economic pressure and enhancing decision-making power of women. So this is really where CVA can have an impact, because I remind you, cash and voucher assistance are really trying to improve a situation where financial barriers and economic barriers are the main barriers. Where other barriers are the main problem, CVA will not have an impact. And it's the call is really, we realize that the CVA alone is not enough. Next slide, please. In fact, you can see from, as you can see from this table that is really talking again about the child and maternal framework of malnutrition, you can see that most of the impact of CVA is consistently on household food expenditure, household food consumption, and dietary diversity. However, when CVA is combined with other nutrition-sensitive intervention or other nutrition-specific intervention, CVA can be effective also in improving dietary diversity of children. And there is a growing body of evidence that is showing the improvement of the dietary diversity of women. When it comes to the nutritional status, the evidence is mixed. So somehow is not reliable, sometimes is not available, especially from humanitarian setting. Most of the evidence that has been used to show the impact and the effectiveness of CVA come from the development setting. So the message here is really, we need to invest more in evidence generation to demonstrate how CVA can be impactful also to prevent wasting. But we also have to acknowledge that it's very important to combine cash and voucher assistance with specific nutrition or health interventions. Next slide, please. So let's have a look at some of the important findings that we have on the evidence and the use of cash transfer as a modality. Next slide, please. There have been a number of evidence review, but one that was quite consistent and important was the meta-analysis that was done by Manley and all in 2020, where they reviewed 74 papers on 40 programs. Most of these programs were really, again, from development setting and mainly looking at prevention of stunting. So their review showed how constantly CVA has been effective in decreasing stunting. Thought not so we don't have enough evidence to say the same for wasting. And let's have a look at next slide, please, to some of these factors that were really correlated to positive outcome, to higher nutritional outcomes. In these programs, we have seen that beneficiaries were receiving higher transfer values. So in many cases, these programs were designed in the way they were referred to health services. So beneficiaries that had a higher nutritional outcomes, they had better access to health services. In many instances, these beneficiaries were older mothers. And in some of these programs, conditional cash transfer was used to increase attendance of health services. However, we've also seen that the use of conditional cash transfer can have some detrimental effect on other outcomes. So as the Global Crash Working Group, we do not encourage the use of hard conditionalities. At least if you have to use them, just use soft conditionalities. Next slide, please. So we don't have research that is really telling us what's the difference between the two modalities, between cash and vouchers. But let's have a look at when vouchers are used, what is the evidence telling us? So in most of the cases, vouchers are used to access to fresh food. They're generally provided as top-up for pregnant and breastfeeding women and children under 2. And they have constantly proven to increase dietary diversity as houses level. However, contrary as like many people think, they will be less successful in increasing dietary diversity at individual level. In some cases, the evidence and guidance note talk about a meta-evaluation that was done by ACF, where fresh food vouchers were correlated with the lower level of anemia, and they increased the nutritional program attendance, and they have reduced the acute malnutrition level. But in other cases, we have seen that when commodity vouchers were used, they actually had some negative effect on other nutritional values. So as I said, there is no like a consensus, there is not a strict position on voucher or cash are the best modality. It's really important to conduct a feasibility and risk analysis and see what's the most appropriate modality in your context. Next slide, please. I would like to share with you some of interesting findings from a recent pilot that Save the Children did in humanitarian setting to try to provide some of this evidence that, as I was always saying, we are missing about the use of CVA to prevent wasting, or the use of CVA in more type of humanitarian setting. Next slide, please. And I just want to remind you that one of the main approaches that we use in Save the Children is the Resourcing Families for Better Nutrition Common Approach. You can play the animation, Sona, where the core components are really the provision of a regular cash or voucher assistance for pregnant women and caregivers of children under 2 during the first 1,000 days of life, combined with the SPCC and the linkages to health and nutrition services. Other components are considered optional and they are not always included. Next slide, please. So in this pilot, we have targeted 3 protracted crises, 3 humanitarian settings with high level of acute malnutrition. In Yemen, the purpose of CVA was really to improve nutritional adequacy, but mainly to cover a series of basic needs. And we provided 6 rounds of multipurpose cash assistance combined with SPCC, and we targeted houses with pregnant and breastfeeding women and children under 2, but also poor houses. In South Sudan, we had a slightly different approach. We targeted houses that were houses with some children that completed their treatment services and were discharged by OTP. And the purpose of the CVA was really to prevent relapse. In South Sudan, we provided 3 rounds of multipurpose cash assistance combined with SBCC. In some cases, when the families were still in treatment, they were still receiving MAM treatment services. In Afghanistan, similarly to Yemen, CVA had the purpose to improve access to basic needs. We targeted poor houses with pregnant and breastfeeding women and children under 2. But the design was really trying to provide multipurpose cash assistance for the houses and a top-up for these individuals member at risk. Next slide, please. So what were the outcomes of this pilot in humanitarian setting? Really similar to the status of the evidence that is illustrated by the evidence and guidance note. So we had some improvement of nutritional status in Yemen, not significant improvement of nutritional status in Afghanistan, but quite significant improvement of the nutritional status of both pregnant and breastfeeding women and children under 5 in South Sudan. So again, a mixed type of evidence. However, we saw an improvement of the dietary diversity of the individuals, both the children and the mother, but more significantly for the mothers. The two outcomes that saw the most significant improvement were really, as usual, households' food security and the capacity of the households to meet basic needs, and the reduced use of negative coping strategies. We also saw, as I said before, an improvement in terms of decision-making of women. They were more involved in the decision-making on expenditure on food expenditure and health expenditures. Next slide, please. From a program perspective, I also wanted to share very quickly some interesting findings. We realized that really context, as usual, context matters. So it's very important to design the program in a way that is tailored to the context. The HSBCC messages, the transfer amount, it's important to analyze what's the level of income. Sometimes we gave not the 100% of the MEB, but after we realized that people actually they didn't have any other sources of income. It's very important to have a discussion with the communities to set the targeting criteria. Categorical targeting might not always be the most appropriate when, especially when you have very, very high level of needs in the communities. So it was successful really to set up a mix of categorical and not categorical targeting. It was very important to establish protocols with the nutrition and health providers for referral to health services, but also to have experts that allocated enough time to work with the team. Very often we do not have, we have either the nutrition team or the cash team that is leading the program, but it's very important to allocate enough time from both the teams and from the monitoring and evaluation team as well to have the better outcomes. And yeah, the time is everything. It's important not to have SBCC activities that start after the cash distribution. It's important to have cash and SBCC that have an aligned type of implementation. Next slide, please. I would like to talk about some of the common challenges around and myth around the use of CVA. Very often people think that if we provide cash voucher assistance to pregnant women, we increase we can increase pregnancy at community level. We can encourage an increase of natal rates. However, the evidence shows that this is not actually happening. In most of the countries where cash was used as social protection programs, in Honduras and in other studies, we have found out that actually the provision of cash assistance has reduced early marriage and reduced the level of natality. So really work closely with health services in the communities, try to, there are ways to prevent this type of risk, but there's no evidence that is showing CVA can increase the level of pregnancy in the communities. And next slide, please. Similarly, very often practitioners think that the use of CVA could increase if provided to malnourished children. It increases the attitude of communities to keep their child malnourished just with the purpose of getting the assistance. So there is anecdotal evidence that this has happened in some countries. However, it was poorly documented. So the evidence and guidance note recommend that malnutrition status is not used as the sole criteria for targeting houses and beneficiaries for programs that aim at preventing malnutrition. Specifically, it is recommended to provide CVA to caregivers of some or mom children that are already enrolled in a CMAM program. And as a other way to prevent this risk, the evidence and guidance not promote to use a one-off registration to avoid to do a rolling type of registration. However, as I said, it's possible to target this type of individuals when they are, when the purpose is a curative approach. Next slide, please. So I'm going to stop here. There is more to say on the use of CVA for nutrition outcomes. However, the message is really we need to learn more on how CVA can prevent wasting, and we have a growing body of evidence that is showing the effectiveness on the intermediate outcomes. So we really encourage you to scale and continue to invest in this typology of approaches. There are a list of resources that are available to guide practitioners in set up a project that is using CVA for nutrition outcome. As you can see in this slide, please don't hesitate to get in touch with us, the global working group on CVA for nutrition under the nutrition cluster. And I'm going to hand over to you, Mabaza, for any Q&A.
Thank you very much, Marina, for the very comprehensive presentation, and especially the evidence that has been presented in terms of the benefits of CVA. Without much ado about anything, I'm going to request that one of our Q&A managers, Mr. Sunini, reads out the two questions that have been fielded by the floor for you to be able to respond to them. Over to you, Mr. Sunini. Thank you.
Thank you, Mabaza. Thank you, Maria, for the great presentation. We have received two questions. I think I will just read all together. The first one is from Sue Downline. The question is, how transfer value is calculated when it is given to increase access to treatment services? That was the first one. And the second question was from Anne from UNOPS. The question reads, can you provide an example of how cash transfer can practically be complemented with social behavior change communication, SPCC, in humanitarian settings which encounter a high level of insecurity? What was the approach to SPCC? Over to you, Maria. Thank you.
Thank you. Very good questions. I'm going to be very fast because we are running a bit late. So when CVA is provided to access to treatment, typically it is designed to cover any costs that are associated to the access to the treatment services. So any transportation costs or any cost related to accommodation, any cost that for inpatient care, for when the caregivers have to stay in the OTP centers, or any cost that they have to incur, to access and utilize treatment. Recently in Nigeria, for instance, they were also trying to understand if patients have other costs like to access to medicines, or if they have any other kit that is not provided by the facility. So you can really work with the health services and try to understand what are these economic barriers that these families are facing. And it's important to remember that we have to link these typology of approaches with what is already in place in the communities. If these families are receiving, for instance, CVA to cover food assistance or to cover multipurpose cash assistance, they will receive their assistance to cover basic needs there. So it's important that we complement our work program with what households can receive from other partners. And for the second question, very good question. So in this humanitarian setting where we have seen that it takes time to set up groups like we typically do now when we use long-term programming as BCC approaches, and we try to really establish groups of influence for all the audience that is involved on this behavior change. The teams in the field, they have used the existing platform. So if they already had a mother-to-mother group or father-to-father groups, they were using them. If they didn't have, they were using available community groups that are already in place for IYCFE, so for this type of messages. And similarly, they have used what is already in place in terms of the delivery platform for the messages. So sometimes it was through mobile money operators that were used for the cash assistance. Other times was through like radio, or it depends on the context really, but we had to act fast, so we were not proposing something new, but we were building on what was available. And we were linking with any other existing activities like individual counseling for these cases that were in need of referral. But definitely design of SPCC in humanitarian setting is also one of the topic where further evidence is needed. So yeah, any program that can be documented and provide more insight how to do it faster would be more than welcome. Over to you, Mabasa.
Thank you very much for the responses. We seem to be having a few more questions that are coming through, but for purposes of our time, we're going to go next to the other presentation, and we'll find ways of responding to the questions that have been fielded. Two more. So over to you, John Nelson.
Yes, hi. Thanks, Mabasa, and thanks everyone for giving me the opportunity here to speak about cash and voucher assistance in Myanmar. It was great to already receive that really interesting presentation from Marina. I learned a lot myself, so this is a great opportunity, hopefully for all the Myanmar colleagues on the call. So as a bit of introduction, my name is John Nelson. I'm a cash and markets advisor supporting Mercy Corps and helping to co-chair the Myanmar Cash Working Group. I've been working on Myanmar since 2020. Next slide, please. So today I'll give that kind of broad overview of CVA in Myanmar, starting with some context, then go into some facts around the overall cash and voucher landscape in Myanmar, looking at some of our 5W data. I'll go into a little bit about benefits of CVA in Myanmar, some challenges, some recent innovations, and conclude with opportunities for collaboration with our nutrition actors. Great. So in terms of the context, and I know not everyone here is working specifically on Myanmar, so this might be a good opportunity to kind of get up to speed. But in In recent years, really, cash and voucher assistance has really both the amount and number of people reached has increased significantly. This was particularly the case in 2020, when the Myanmar authorities really began to grant more. Well, they became more accepting of CVA as a modality. Before that, there was quite a resistance, given that many of the areas we were working were high, or where there was quite a bit of conflict. So due to COVID and an expansion of like some of the social protection cash transfers, there was quite an expansion by many humanitarian partners to implement CVA. Of course, as all of you know, there has been the recent political crisis and conflict, which has resulted in now 17.6 million people in need of humanitarian assistance, spread really throughout the entire country. You can see that map on the left there. And there's currently 1.5 million people displaced across Myanmar, and this number is growing on a weekly basis. So CVA has really become an important tool for many humanitarian actors. Formal access is quite difficult in the areas where most of the needs lie, and cash is definitely a lower profile type response. So many actors have defaulted to using CVA in many areas throughout the country. Also, in-kind has faced many challenges. So there has been lots of restrictions on imports, high fuel costs, transport. Trying to get approvals for transport has been challenging. And of course, it's more visible. An important thing to note is that much of the CVA assistance is being implemented via remote management and through local partners. Many international agencies do not have direct access to implement, so it's very much a local partner type response, which has ramifications for implementing. Next slide, please. Some general facts around CVA. So as I mentioned, the total amount of CVA dispersed in Myanmar has increased significantly, and this is even with the some of the restrictions. So there was 36 million distributed in 2020, 39 million in 2021, and now 49 million in 2022. The number of people who have received CVA has also increased significantly. So up from 400,000 in 2020 up to 1.1 in 2021, and now 1.5 million in 2022. We expect these numbers just to continue to increase in 2023, as well as the needs continue to increase. In 2022, there were 42 organizations reporting CVA activities in Myanmar. So these are the organizations that reported into the Cash Working Group, 5Ws, of which there were also 97 local implementing partners of those 42 that were utilized. So we had quite a comprehensive data set of what CVA activities were being implemented throughout the country. Cash and envelope continues to be the primary delivery mechanism, which accounts for 84% of all the assistance. It's very high compared to other contexts, and this is really a result of this issue around government restrictions and really needing to operate in a low profile manner. Although, as I'll mention a little bit later, we do hope to expand digital type delivery where appropriate. Looking more specific at nutrition activities, of the total 49 million of CVA that was dispersed, so 3.83 million was dispersed under nutrition activities, reaching a total of 100,000 people. Next slide. So what are some benefits of CVA that well, these also apply to many contexts, but particularly in Myanmar? So well, obviously it provides program participants freedom to choose and prioritize the items that they need the most. We have seen from assessment data in many locations that cash is often the preferred modality among recipients. This is a data point that we often collect in our cash programs. And CVA can also help support local markets and the economy. We know that in many cases, a lot of the cash that's spent in the humanitarian programs is spent at a very, very local level, at the community level. And those local vendors are the ones that are often benefiting from the support. This is even more so with the conflict and difficulties accessing the main market. CVA can also be, as I mentioned, implemented in that discrete and low profile manner and reduces security risks. It's also often more efficient and cost-effective means of delivering the assistance. We've done some assessments on this, and it is often both quicker and more cost-effective, even with some of the challenges that we see with the financial service provider. Next slide. So lots of challenges in Myanmar, as you all know and experience on a regular basis. And these are things that, particularly as the Cash Working Group, we are looking at trying to support partners on. So the big one, right, is being able to just transfer, remit cash into Myanmar and then around Myanmar to the locations where that's needed. Many organizations no longer have valid registrations or MOUs with particular line ministries, and that makes it particularly challenging to both to use the formal banking sector. While we would love to start moving more towards digital forms of delivery, there's lots of concerns over data privacy and security for many program participants. The authorities have quite a lot of eyes on different transfers that are formally of FSPs that are formally regulated, and there's concerns for certain areas and beneficiary types that that information could get into the wrong hands. So there's definitely concerns around that. There's lots of issues around coordination and information sharing, given that these issues around the registration and not necessarily being able to freely work in certain areas across the country. Agencies are very hesitant to provide a lot of information at an interagency level. So trying to coordinate a response, not just cash, but all responses is quite challenging. In many areas, accessing the main markets is also really, really difficult. So there's lots of conflict, there's checkpoints. And so we really need to make sure that there is a location, there is a place where program participants can spend the cash that they receive and receive the types of items that they need. And so often this is at the very local level, and we are encouraging partners to be able to assess that. Given that there's not a lot of direct implementation and it's very remote management and very difficult locations, there's often a lack of transparency on on the distributions and often a lack of being able to monitor the activities on the ground. So this is a big challenge. We also, because it's cash and envelope, and often the cash has to move physically from a main township center to a distribution site that may be in a rural location. Large amounts of cash often have to be transported. So that definitely raises lots of security risk, fraud risk that we're trying to minimize where possible. Also, because many local actors still need additional capacity building to implement CVA with quality. So there's many very local actors that maybe haven't implemented programs in the past, and so there's a big effort to build the capacity of local actors, especially around CVA. Next slide. Yeah, so there's a few innovations that we are really trying to support on. So one is really this issue around trying to remit funds and transfer funds to different locations where it's needed. So we've been really working on kind of a two-pronged approach, one with the more formal sector, whether that's formal banks, but often these what we call financial service providers that are formally regulated, like mobile money companies. There's some photos of some of their logos there. Also informal financial service providers. So we are working, many partners in the Cash Working Group have been working closely with informal financial service providers. We call them hundis in Myanmar, similar to hawalas in other contexts, and local cash agents that can be able to provide the funds in the locations that we need. There is an increasing desire to use mobile money, e-cash, e-vouchers, and many partners have done this to varying degrees in different locations. Immediately after the military takeover in 2021, there was a lot of difficulties with this group of companies, given there was a major liquidity shortage. There was also a lot of uncertainty around their business models, and so they do seem to have restructured a lot of their business models, and the liquidity situation has stabilized to some extent. So there is an interest, I think, to use this in appropriate context. So as I mentioned, there's some context or some locations where maybe it's more sensitive and it's not so appropriate, but maybe in others it can be. And again, we want to really work on building the capacity of local actors around implementation of CVA, and I think that this will really help with the sustainability of cash and voucher systems going forward, given that these are the actors that will be there long term. Next slide. Yeah, so I think there's quite a few areas for collaboration with Myanmar nutrition actors. I mean, first of all, it's great that the nutrition cluster and the Cash Working Group have already had a few meetings to discuss some of these topics, and now this really great webinar, I think, brings everyone together with some really good technical expertise on the topic, and also bringing in that global perspective, I think, is really great. What we will, maybe some areas for collaboration, we will I think continue to make sure that we're participating and working in each other's working groups. I think there's especially opportunities at the subnational level in Myanmar, right? We're really trying to build up the subnational coordination and technical working group structures. This is part of the new humanitarian coordination architecture that's been approved, and so we will. I think there's a lot of opportunities there, and hopefully we can continue that collaboration. The Cash Working Group, we're really, one of our key priorities, at least over the next few months, is to roll out a operational guidance and strategy on multi-purpose cash assistance. And as Marina mentioned, that does fit into some extent on for cash for nutrition. So I think there's definitely opportunities here for integration, at least discussion of how nutrition maybe fits into that work, and how perhaps there's some nutrition objectives that might be able to be met by MPCA. We have a commitment to support with cash feasibility tools and modality decision-making, assessments, matrices, tools. I think this is really important, especially for nutrition actors where it's not so clear, which modality to use. There's some common tools that can be used for all actors, and when deciding whether or not to utilize in kind, for example, or cash and voucher. And then also the delivery mechanism is quite key in Myanmar. And then regularly share information around financial service providers and market price monitoring. These are also key priorities for us. And I think we want to really make sure that we know which items, for example, in the markets are key for nutrition actors, and make sure those are incorporated into some of our work. Next slide. Yeah, so despite the challenges, the CVA is still a very crucial modality for reaching those in need. We hope that it can also be an important tool for meeting nutrition program objectives, as well as other cluster specific objectives, and we're here to support that process. Yeah, and again, we're always working on resources and other technical tools, and happy to provide support as necessary. So please, don't hesitate to reach out and help this discussion continue. So I'll leave it there for now, and over to Mabasa. Thanks.
Thank you very much, John. We are moving on to the next presentation from Metza. Thank you.
Thank you very much, Mabasa. Thank you, John and Marina, for a great presentation so far. I think it's been truly refreshing to talk about CVA and nutrition over the past couple of weeks and months. And I will just make a quick introduction, I think, for all the participants, and say that it's not a new topic, I think, for Myanmar, but the context is different, and we are trying to talk about CVA in nutrition in Myanmar today, which might be quite different from some of the early starts that we have had in 2014 or 15. With this in mind, we will share, I would say, parts of experience of Save the Children that have been generated in Myanmar, together with some evidence that was created in the programs that have been implemented across the country. And just to lead you into the presentation, if we can go to the next slide, it's going to be, I would say, a program overview of what we have been doing for the past almost 10 years now, because as I said, utilization of cash for nutrition in Myanmar is not a new topic, and we don't want to kind of just dismiss the experience that has been generated over the past 8 or 9 years, but we do want to learn from it and adapt it for the current context and for the current challenges that Myanmar is facing. Historically, if we can say it like that, the overall kind of goal for MCCT programs in Myanmar has always been targeting pregnant and breastfeeding women and children in the critical window of 1,000 days to have improved nutritional outcomes. And then prevention of stunting has been, I would say, a repeating topic or repeating goal for many of the organization, including Save the Children, who have been working on this. Most common intervention in this sense was actually a cash plus intervention. And this has been, I think, ongoing learning in terms of what this plus is and what it constitutes of and how it can be done best. With this in mind, just to mention that, initial programs were designed in Chin and Rakhine, dating back almost to 2014. And then we have had expansion, at least on Save the Children side, to Delta, Dry Zone, Shan, Kachin, and peri-urban Yangon. We're also aware that other actors have been working in Kaya, in Kayin, in Nagaland, in other areas of the country. And all these programs have generated, I would say, substantial body of evidence on what works in Myanmar, which is in good alignment with part of what Marina was sharing. And we will try to dive into this briefly. One thing to mention, I think, that is specific to Myanmar, and that is, I would say, aligned with global learning, is that basically the length of exposure has been a significant component in reducing stunting, and most of the programs that we will talk about have had 24 to 36 months of exposure for the beneficiaries. So this is, I think, a component that will come in later as important when we talk about some conclusions and lessons learned. Next slide, please. So in terms of MCCT design, and MCCT has been, I would say, accepted term across the country for the cash plus interventions aiming to prevent stunting and improve nutritional outcomes for the children in the critical 1,000 days. What we actually emphasize is that it is an evidence-based approach, but it has evolved with localized learning over time. And what is very important to know here, I think, is that this localized learning is not Myanmar only, but even within specific regions in Myanmar, learning has shown that, specific fine-tuning or adapting of the program can actually give us a bit better result, as we will learn from a couple of examples. Based on the previous learning, what we can say for sure is that it does encourage monthly or bi-monthly cash transfer, aiming to include all mothers, so looking and pregnant women, so looking at concept of universality, ensuring that there is a mandatory complementing social behavior change communication activities, and then continuous focus on nutritional outcomes, even if other activities are included in the program. Next slide, please. So the cash transfer element, as we said, usually would be looking at a minimum of 24 months with focus on supplementary feeding. So we are talking about lower value of cash transfers that are provided more frequently rather than a short term, but in higher in value number of transfers. What we have learned is actually that because the SBCC needs the time to kind of kick in and start being applied by the beneficiaries, we need this lengthy exposure and kind of continuous recommendation being provided in order to ensure the behavior change. Targeting has usually been from second trimester to the 23rd month of age. However, in many programs, we have been deciding more frequently than not to cut off registration to ensure at least 1 year exposure in the program. This has been, I would say, both pragmatic decision because shorter exposure both undermines the kind of overall result, but at the same time, it really doesn't provide, it kind of is a significant administrative burden if we are enrolling beneficiaries for a short term of 2 or 3 months. It didn't have much sense. In terms of transfer value, as it was mentioned by Marina, there were several, I would say, pathways that Save the Children in Myanmar and several other Myanmar actors actually have been taking. But the famous 15,000 chat number has been actually in place for quite some time before the current crisis, and has been widely accepted as an amount that actually ensures that sufficient level of diverse food is provided for the mother and for the child. Obviously, in 2020, since 2021 and 2022, we are looking at increase in prices actually of food commodities, and therefore there has been, I would say, different attempts to align this number to the current reality. We are currently looking at 20 to 25,000 CHAD, depending on program to program. But we are doing a current cost of the diet analysis and trying to both understand, the movement of the market. And this will be, I think, one of the key learnings in this year that we will try to pin down and understand what should be the value in the current context and which logic should it follow. In terms of transfer modalities, both mobile transfers and cash in envelope are used in our programming. Mobile transfers being preferred, as John has mentioned, for accountability purposes, but also in sense of current logistic challenges. It just seemed more feasible. But then for the hard to reach areas and areas where mobile transfers are not feasible, we are kind of implementing cash in envelope as a mechanism to ensure that this component of universality is reached. Also in some of the areas, access to mobile services and mobile phones, as well as digital literacy, has shown us that it is not very feasible model, and therefore it was kind of brought back to cash in envelope or physical cash distribution. In terms of changes introduced, basically envelope to mobile money transfer and back to envelopes in some regions, I would say. Changes in basic amount, as we already were mentioning, and then cash for antenatal visits as part of I would say good practices, occasional top-ups, but also some, I would say, innovation that we will talk about in the next slides. Next slide, please. Thank you. So in terms of SBCC design, I think that the key element that we want to mention is that it must be context, but also in current setting, access-driven design of SBCC component. So one size fits all really is impossible in this sense, because it should be driven by a formative research or a barrier analysis that will actually show us which behaviors are not being applied and they should be, and then which kind of negative behaviors are present in the communities or with the population, and that we want to kind of reduce them or impact them in other way. Delivery of this is based on specific needs, so it can be via mother groups, individual coaching, IVR or integrated voice elements, phone calls or other methodologies. This really depends on whether it's a broad message that needs to be heard by everyone, or is a very specific set of messaging that is intended for a group of mothers or specific mother that you're trying to target. In terms of the mandatory elements, we most often are looking at monthly mother care group meetings, family MUAC and referrals through the community capacity strengthening model, and then home visiting and counseling as something that can strengthen the capacities of those mothers who might be falling behind or cannot keep up with the pace of the care group model, or just need additional support with their children. And then in terms of context-specific elements, we would be looking at various types of engagement sessions and community dialogues, whether they're referring to role of mothers or gender elements, but we might be looking at cooking demonstration, roles of fathers and male caregivers. In areas where we have a bit more access to technology, we would be looking at digital midwife, IVR and hotline counseling, as well as different types of campaigns, including exclusive breastfeeding campaign, but also I would say healthy nutrition for mothers or healthy choices campaign. Next slide, please. So we're going to just take a quick look into two examples of a program design that has been designed for a development context, but then evolving to more, I would say, emergency context as we were progressing. So Healthy Choices has been designed in a peri-urban area, so it included, I would say, a hybrid of both SBCC in person and then IVR models that we are providing through digital midwife character and hotline counseling. But it also, for example, one of the peculiarities or interesting facts about the model was that what we learned in the peri-urban context, that people rely a lot on the food vendors as a source of food. So we included food vendors in the training. We included workplace nutrition because that's where a lot of consumption is happening. And therefore, we included those kind of interaction spots as they are important for the target group. In a more rural program, this would not be the case in most places because we wouldn't have those interaction points with the beneficiaries, and therefore we wouldn't use them. The program also included a 6 months exclusive breastfeeding campaign as well as Healthy Choice campaign, really trying to push the utilization of healthy foods by the women of reproductive age. But then also we included digital literacy training because there were, as we spotted, there was a number of beneficiaries that couldn't actually utilize digital services, and we needed to capacitate them before we actually could provide them with these services. Next slide, please. And then as a different example, maybe this program has been implemented in rural area and was looking at mother care group model as a really standard for most of these programs, but then looking more at engagement session with key influencers, whether it's a mother-in-law or a male caregiver. We tried to introduce smaller group counseling so that there is more interaction and more chance for mothers to actually ask questions that they need answered. Family MUAC and referrals have been established as a screening practice, and then one adaptation after health system suffered challenges was actually referral to antenatal care, because we have noted that there is a reduction in number of antenatal visits and some not visiting at all. And for example, in this component, we have also utilized cash to actually cover the cost, because reaching the health facilities has become a challenge for a number of families living in remote areas. Aside from this program initially has been designed as SBCC only, without the cash transfers, because we were looking at to which extent the nutritional outcomes can be affected or impacted by SBCC only. But then after the crisis has kicked in, number of people have lost their jobs. We have seen drop in income. And actually, together with Lyft, who has been the donor for the program, we have decided to include cash transfers in the program itself. So these are just kind of two examples that look at different elements that can be introduced together with cash, but also to ensure that cash works. Because if we can move to the next slide, basically what we learned so far, I think one of the key learnings, even before the coup, was that cash alone will not work. And this has came from the legacy randomized controlled trial that has demonstrated that cash without SBCC will have limited impact to the stunting reduction and even to dietary diversity as such. Aside from that, we do look at digital cash transfers attached with SBCC, whether it's in person or IVR, as those seem to be the best solution to support most vulnerable families, especially in areas where there is mobile phone coverage. Where there isn't, obviously, we would be looking at physical cash transfers. Family MUAC and community capacity strengthening is key for successful screening, as we have seen it so far. But this also needs to be advanced with time in order to ensure that there is, I would say, adequate screening rate, but also adequate capacities to do those screening in the communities. We are looking to consider targeted cash for other purposes, transfer costs to health centers for antenatal visits, cash after treatment to prevent relapse and ensure that there is, I would say, sustained benefit of those therapeutic interventions. And then one of the key learnings that has been around for quite some time, and some of you may be hearing it for the second or third or fifth time, is that the lesser amounts that are provided more frequently do ensure improved control of those financial means by women. Accumulating larger amounts for several months of transfer, or just kind of relying on larger transfers, in many cases has proven to cause loss of control over funds by women, as they would be considered almost as an investment fund or fund for productive assets that in many cases in Myanmar are still pretty much controlled by men, or men would have much stronger say over utilization of these funds. Next slide, please. Another set of lessons definitely is that cash transfers, they must be combined with SBCC. We have noted that this will not be effective if cash only is provided. But then length of exposure to program is really important when considering the type of impact that we wish to see. If we are looking for behavior change, and if we are looking to prevention of stunting as a nutritional outcome that we are hoping to achieve, the best results have been shown among those participants with longest exposure to the programs of 30 months and above. And then final note on SBCC, I would say, would be to deliver layered, frequent, and salient SBCC activities. What this means is actually that we cannot rely, on one level of interaction or one point of interaction. There will just be not sufficient time, no matter what type of that interaction is. It needs to be through multiple channels and kind of prioritizing interpersonal communication when possible. And we know that this is a challenge lately in Myanmar. It has to be salient, it has to be creating engaging and participatory activities, and kind of looking at all family members and not only the mother as maybe primary caregiver. And then frequency should be following at least the cash transfer, so at least once a month or once every 2 months, but really kind of even more in the key life stages, especially as we are kind of ending the exclusive breastfeeding stage and adding the additional foods into the diet. It should be definitely considered more often. Next slide, please. And then just maybe to mention a couple of challenges as we are kind of programming in Myanmar today. Obviously, John has already mentioned cash transfer challenges. There's both, I would say, reduced number of channels, but also increased control over cash transfers across the country. And this is something that calls for innovation, but also calls for caution in many cases. And we need to be very careful in terms of the beneficiary data and how do we ensure the beneficiary data remains protected. We are looking at pressing socioeconomic conditions that cause use of funds for debt repayment and other needs. And what we see is actually people prioritizing kind of caloric intake and caloric quantity over quality of foods, which is perfectly normal in the conditions that we see, but actually undermines the nutritional outcomes. We are looking at access challenges that can hamper SBCC interventions and limit the time with the beneficiaries, but also the quality of this interaction. And we need to kind of further advance the digital elements, but also work on the digital literacy among the population. And then health system challenges, obviously affecting both screening, but also care and treatment provided by the facilities, and as something that can definitely significantly affect the overall outcomes. And I believe this was the last slide. So I will end here just by saying, like, while there are a number of challenges, the programming still delivers results. And while we might not see the progress that we were seeing in, as we were seeing in 2018 or 19 in terms of the numbers, in terms of current crisis, even sustaining nutritional outcomes can be considered a significant success, because otherwise they would be deteriorating heavily, as we see in some areas where these services have been stopped. I will stop here and looking forward to hearing the discussion. Thank you very much. Mabasa, over to you.
Thank you very much, Mirza, for the presentation. That's quite detailed and more focused on experiences and nuances that are particularly focused for Myanmar. I also want to thank John Nelson earlier for the presentation on CVA. And we have a list of questions that I think can now be answered at this point in time, some of whom can at best be answered by John Nelson, and others, of course, Mirza can probably respond because of the contextual cash voucher assistance issues that you've presented, and can basically help to answer the questions. I'll give this over to my colleague, Mr. Sunini, to read out some of the questions that have not been answered online, so that perhaps the presenters or anybody who has a capability could answer to those questions. Over to you, Mr. Sunini. Thank you.
Thank you, Mr. Mawaza and presenters. I can see there is only one answer open, but I can see John has been typing in the chat, but I would just read anyway. The question is from Yuminte, Siam Yuminte. Let me read that. Is there any example related to voucher assistance program implementation? How do you usually choose the suppliers, service providers, especially in the field level, in order to assess beneficiaries easily? Over to you, the panelists. Thank you.
Well, I was typing away here, but yeah, I can say that yeah, so voucher support is not, I would say it's definitely not as frequently used as it was in the past. And I think this is in large part due to the access constraints and the visibility that some voucher programs have, having the paper vouchers or the e-vouchers with specific hardware. So again, the approach has often now been tried to keep it low profile as much as possible. But nonetheless, there are partners that are still using it. I think, I mean, some nutrition actors have used it in the past, like for certain fresh foods, I think. But based on the data that we recently collected, mostly in the health and protection sectors, I will say that it's important to choose, like every program has different objectives, right? So it's very important to choose a supplier for using vouchers that has the types of items that you need to meet your particular program objectives. So usually if you use a voucher, it's to meet certain program objectives, specific program objectives that maybe unrestricted cash might not be able to meet, whether that's wash or protection or health. And so it's important that those items are available with that vendor. And again, this is like mostly done at the local field level, identifying the vendors that have those items. And there's definitely assessments and tools available to check and make sure you have that information documented. Hope that helps. And I'll post this.
Thank you very much, Nelson. But just before you go away, there was a question from one of the participants that wanted an indication of the breakdown of the 3 million CVA that was focused for nutrition. I think it was emanating from a presentation. Do you have an idea about the breakdown of that kind of support that was nutrition focused? Thank you.
Yeah, I don't have the figures off the top of my head, but yeah, the majority was maternal child cash transfer program. This is the program that Mirza was presenting on, and it has been kind of the flagship, one of the flagship cash transfer programs in Myanmar. It looked like also that some of the school feeding, the WFP school feeding work was also kind of put under the nutrition umbrella and sector, as well as some, like there was some nutrition support for HIV and TB patients. There was some others that were not so, partners weren't explicit, but that was actually the majority there.
Okay, thank you very much for the responses. Maybe we can encourage participants to keep on bring your questions on the Q&A box. And just to answer one question, maybe, that has been fielded, and it was about any evidence that has been generated either globally or in Myanmar in terms of CVA in nutrition and emergencies. I think I could partly cite the IFPRI peer-reviewed publication that demonstrates evidence in terms of CVA, especially the one that is complemented with SPCC, to have quite some impact. I think that information can basically also be shared through the nutrition cluster platforms. This is to point out to the fact that there's quite some evidence out there that does show some impact. Albeit, nevertheless, this evidence was for development nutrition related interventions. And I think, like it has been mentioned earlier on, our interaction right now with the GNC post this webinar is to see to it that resources permitting, some advisor can basically be recruited based on agreed terms of reference to try and come up with tailor-made sort of like guidelines that could be helpful to the Myanmar situation. I want to get back to my colleague, Mr. Sunini, if you still have any question that maybe has not been answered, or maybe if it has been answered, it could actually help that it gets discussed or it gets to be read out publicly as some other questions have been. Thank you.
Thank you, Mr. Mobazer. In fact, there is no more questions in the Q&A box, but I understood that some of the members who are supporting this, some of the administrative members who are supporting this webinar, they also have their own questions, but we do not have the function to put our questions in the Q&A box because we are listed as panelists, although we are not panelists. Maybe can we also
maybe yes, maybe you can go ahead. But first of all, Marina has requested that she wants to take to the floor, and over to you, Marina. And then after that, Mr. Sunini, you can come up with your questions. And if there's anybody else who needs some questions to be addressed, they can also follow after that. Thank you. Over to you, Marina.
Thank you. There were some very important questions in the chat box, and they were, many of them, they were related to restrictions, they were related to conditionalities. I just wanted to emphasize the importance of conducting constantly a feasibility and appropriateness analysis to choose what is the best modality. We cannot really say for nutrition it's better to use voucher or it's better to use cash. It's very important that we analyze in the context if you want to apply certain restrictions and use voucher, it's very important that you understand if this is strictly needed. If if for any reasons you think that your beneficiaries will not be able to use the cash assistance for the purpose that you are proposing, no? For the nutritious purpose, if you think there are high risk of misuse of the cash assistance. And in some contexts there are, we have seen in some contexts where and this link a little bit to the one of the questions that were posted on the risk and protection. In some contexts, we might see that there are families with child protection concern, where there might be a risk of abuse if we provide the cash assistance. So, but these are very, very, very rare. I just wanted to emphasize, most of the time when we provide cash assistance unconditional and unrestricted, and when we provide it to these families that have highest need, they use it, the analysis of expenditure is always consistent. They use it mainly for food assistance. They use it to purchase food. They use it to cover health expenditures in some cases, and if like 40% of the expenditure is always on food. Remember that vouchers have a cost associated to the setup of the voucher system. You should analyze the situation with the vendors. You should verify that vendors in the local area have the capacity to set up a voucher system. They have the capacity to increase the procurement. They have the capacity to set up a barcode. It's quite labor intense. So yeah, it's very important that practitioners understand that there is a wide level of evidence that is showing how effective cash and unconditional cash can be. I also wanted to emphasize how important it is to understand access to the delivery mechanism. And John made an excellent presentation. So in Myanmar, you have quite a strong analysis that is already in place that you can use, because it's going to be the same for each sector. But is it when there is a challenge in access to certain location, is it possible to switch to another delivery mechanism? What are the limitations that some beneficiaries can have to access to a certain delivery mechanism? I remember if normally for the food assistance program, the head of the house as a male member is the main cash recipient. Ask yourself if this change, if a woman become the recipient, will she have access to this delivery mechanism? Is it a mobile money operator, or what are the requirements that this financial service provider ask to our beneficiaries to use it? So it's just not a replication of what other agencies are doing, but really make sure that the choice of the delivery mechanism and the modality, they fit the purpose. And a very last point, there are always risks associated to the use of cash or voucher, but those are not higher to the risk that can be associated to an in-kind assistance. Very often, we have found out that actually in-kind assistance have higher risk because there is all the logistic part that is associated, no? So risk for our staff, risk for our financial service provider. So it's very important that we conduct this analysis of risk with the communities, with our staff, and we sit down and we identify what are the mitigation measures that we can put in place to reduce this risk. And in most of the cases, even like in acute emergencies, we are able to use cash. So I just wanted to really emphasize these messages. And I'm going to hand it over to you, Mabaza.
Thank you very much, Marina, for coming in on that and the contributions you've made. Like we've discussed earlier, Mr. Sunini or some of the panelists also had some need for clarifications of some issues. Over to you. Thank you.
Thank you, Mr. Mobozer. There is, in fact, one more question in the Q&A. Let me read it aloud because my personal question is also related to the question that was raised in the Q&A. The question is from Tia Onzo Kai. I read, in-kind assistance is seemingly low according to what IDPs claimed, as the local groceries are getting rocket high. So this is the question from Tia Onzo Kai, and as I mentioned, I also have a similar question in line with that. My question is, what are the considerations in the catch and voucher programming, like setting the value in the context of inflation is really high, and also inflation rates are rapidly changing. Thank you very much, and over to you, the panelists.
Yeah, sure. I can maybe take this one, and then others can jump in. But yeah, I'm not sure exactly what the question means by in-kind assistance is seemingly low, but I will say that, yeah, I mean, we're definitely concerned about the rate of inflation and making sure that program participants can buy the amount of items that we would expect them to buy. So as the cash working group, we have we have a minimum expenditure basket, but also a survival minimum expenditure basket. And with the survival minimum expenditure basket, we update this on a quarterly basis to account for the increase in market prices. Fortunately, the prices have stabilized just a bit compared to what they were late last year, but nonetheless, we do update this on a quarterly basis, and we would expect all partners to also evaluate whether or not their transfer values are still relevant given the increase in prices. We have regular market monitoring from WFP of the core basic food commodities, and also Mercy Corps, we monitor a basket of both food and non-food items. Not everywhere, but in Rakhine and also the Southeast. So, there's also other partners that also monitor. We share that information regularly. Thank you.
Thank you very much, John, for that response. I see there's a report of a hand that is raised. Please, you can go ahead to ask the question by Mohammed. Mohammed has a hand raised. Please go ahead if you want to seek any clarification from the panelists or from the floor.
Yes, thank you for giving me floor. Good morning, good afternoon, and good evening to the colleague. I'm Muhammad Ayub from the ICRC, working in the economic security team leader based in the northern Yakan. My question is not specifically this. I'm just seeking some support and suggestion from the audience and also from your side. Here, as you may already had, there is the situation, especially my consideration for the Northern Rakhine State. We don't have the much more voucher cash and voucher access, as no available money transfer agent here in the Northern Rakhine State. Even some particular agency wanted to work on the cash and voucher in terms of the relief and livelihood and nutrition as well. So for in this concern, what do you suggest to go for the cash and voucher assistance for this? And also, if we see that generally, we don't know the exactly GAM rate, SAM rate, and MEM rate here in the Northern Rakhine State, because since 2015, we are not able to do nutrition assessment, either the SMART survey or a quick assessment. So thank you. That's all from my side. Over to you.
Thank you very much for that very important question. I was wondering if a bit the first part of that question could be answered by either of our colleagues, John Nelson or maybe Mirza, who have quite some good understanding of the mechanics of the operations of the CVA. But before you come in, I could probably just touch a little bit on the absence of GAM, SAM, or MAM prevalence sort of like results that are very recent in terms of the situation in Myanmar. We recognize that to be a very huge gap, and we're trying to work under very difficult conditions of travel authorizations, of other types of authorizations, to try and see if some kind of assessments can actually be done to provide a picture of the prevalence of severe acute malnutrition and such other issues. Having said that, I wanted to also just highlight that for purposes of implementing cash voucher assistance, perhaps strengthening regular screening activities that can identify beneficiaries can be one sort of like a transient method that can be used to plug some of those gaps that are experienced in terms of the current and most recent assessment data that is being experienced. And I think, having said that, I can give it back to other colleagues who can respond, I think, on the first part of the question that maybe relates to lack of agreement in terms of the amounts that are being given out there and the actual needs on the ground, and also the operational issues that have to do with absence of facilities or methods to provide the CVA in some places. Over to you, colleagues. Thank you.
Maybe I'll jump in on the financial service provider one. Yeah, so I mean, yeah, it would be, I mean, this is a bit specific to Northern Rakhine, but as far as I'm aware of, I think there's 2 banks operating still in Mongdo, at least, KBZ and one other, I think it's, yeah, Global Treasure or something. So those banks are still operating, and what I think many partners are still able to either withdraw from special accounts from those banks. I think there's also potentially wave agents as well in Mongdo. I think Northern Rakhine is tricky in the sense that traveling outside of Mongdo is quite challenging for the FSP. So in most cases, if we need to do cash, it has to be carried by the partner. Hopefully after getting some sort of approval from the local authority.
Very much, John, for the response. I think for the sake of our time, I can request that we proceed to the next few other remaining slides on what else needs to be said for this webinar. Thank you. Okay, you can go to the next slide, please. Okay, so we're going to the next steps, and one of which is for any of our partners who needs support from the Global Nutrition Cluster's Technical Alliance. And we've categorized the 4 types of support that might be needed, and of course, the provider. Number 1, if you want remote or in-country technical support, you can always reach out to the Global Nutrition Cluster Technical Alliance for this kind of support. And I think later on, we'll be able to show you how you can access this kind of support online. And secondly, if you want to hire a consultant directly, perhaps to provide any technical support for your agency, the Global Technical Alliance consultant roster is always available. And please, you can always reach out timely so that some arrangements can be made to provide you with these consultants who are on roster. And then thirdly, is if you want a quick technical advice on any issues that you come across in your areas of operation, there's also the GNC help desk that is always on hand to provide that kind of support. Then lastly, we also have those that would require peer support, and that can be obtained on the website written there for the ennet.org, and where you can click request support. Next slide, please. Okay, so that is how you can reach out to the Global Nutrition Cluster Technical Alliance for technical assistance for nutrition emergencies. You go to that link, and then I'll be able to request the support as it were. Next slide, please. Okay, so the previous slide was how you can fill in the information that you require. So before we come to the end of this, unless if there are other people who want to make further contributions or respond to issues, you are being asked to fill out the brief webinar evaluation, which will take less than 5 minutes, and it will pop up when you close the webinar. So on behalf of everyone in Myanmar, the Global Nutrition Cluster Technical Alliance and colleagues, I would like to thank you very much for your full participation throughout this webinar. And like we've already said, we're going to go ahead and request and enlist the support of an advisor to kind of come up with tailor-made guidelines that will be helpful for the situation that we have in terms of CVA in nutrition emergencies in Myanmar. So this is what we see as the way forward following these deliberations through this webinar. Note that the recordings and all the slides will be shared with you for your own information. And please, let's continue to engage on these issues so that we can expand in terms of our reach through CVA for the beneficiaries that are increasing as the situation has become protracted in terms of the humanitarian situation in Myanmar. Thank you very much. If there is anybody who wants to say anything, maybe in conclusion, over to you. Thank you. Otherwise, we've come to the end of our webinar, and many thanks for your participation. I see some quietness, and probably to just say thank you very much for your participation. All the best.
Thank you, Mpasa, for organizing.
Thank you.